So good morning one and all, and today's topic is bone loss and bone loss patterns. And generally if you see the periodontal diseases, in advanced periodontal diseases we see bone loss. How this bone loss is happened and what are the different patterns of bone loss which are taken place in the periodontal diseases we will be seeing today. Okay. So if you see the bone loss patterns and this extension of the inflammation from the marginal gingiva into the periodontal supporting tissues marks the transition from the gingivitis to the periodontal disease. So when the inflammation occurring onto the marginal gingiva, and next how the inflammation from the marginal gingiva into the connective tissue, then onto the periodontal tissues, and then moves on to the periodontal structures, that is periodontal bone. So thereby which is leading to the bone loss. And here if you see the periodontal diseases alters the morphological features of the bone, and in addition to that it also will reduce the bone, and which is explained with a lot of mechanisms. And if you see the pathways of inflammation from the gingiva into the periodontal structure, there is a schematic presentation how the inflammation from the marginal gingiva is moving on to the bone marrow spaces. Here you can see after the inflammation reaches the bone, which extend into the from the gingiva, it spreads on to the marrow spaces, where the marrow spaces were replaced by leukocytic fluid exudate and the blood vessels and proliferating fibroblasts. And later on multinucleated nuclear osteoclasts and mononuclear phagocytes which are increased in number and thereby causing the widening of marrow spaces. And then because of this widening of the marrow spaces, there will be a resorption in the marrow spaces which are causing the thinning of the suprabony trabeculae. Thereby it also leads to the destruction of the bone as well as the bone height. So the mechanism of the bone loss, which is explained by so many mechanisms. Here there are a lot of authors, they have explained the mechanism by explaining what is radius of action. Okay, here the radius of action means the Garrett and Co. reported that there are a lot of factors which are locally produced in the tissues. For example, trauma from occlusion, plaque and calculus. These are the locally factors which are affecting the bone loss near the bone. Okay, along with that, Page and Schroeder, they also explained by explaining the range of effectiveness. That means the distance between the presence of the plaque to the interdental papilla, suppose the distance should be about 1.5 to 2.5 mm, and then the distance between the bacterial plaque to the crest of the bone should be 1.5 to 2.5 mm. Then the bone loss is happening. So it is explained by means of radius of action. Likewise, for angular defects, they have given a range of 2.5 mm, and the larger defects which are extending more than 2.5 mm, that means the distance between the bacterial plaque and the interdental septum should be more than 3.5 mm. Okay. So along with the radius of action, there are a lot of authors which have explained how the bone loss which is happening. That means the rate of bone loss. So here Lowe et al. Explained by saying this theory, that is untreated periodontitis in Sri Lankan tea labourers, the annual rate of bone loss is 0.2 mm in the facial aspect and 0.3 mm in the interproximal aspect. This is about rate of bone loss which is explained by Lowe et al. So after knowing what is bone loss and bone loss patterns, there are a lot of mechanisms which are put forward to explain what is bone loss. Okay. So likewise, if you see the normal scenario where from healthy gums which is becoming the advanced periodontitis, where you can see lot of or advanced bone loss. So here you can see the healthy gums which is a sulcus depth of 2 mm, where it is going to gingivitis because of the presence of the local factors such as plaque and calculus, which is causing or deepening in the periodontal pocket, and because of the deepening of the pocket where you can see bleeding gums as well as swollen gums, and after that this gingivitis is transiting into a moderate periodontitis by altering the root cementum and also because causing the loss of collagen in the connective tissue and periodontal cells degeneration or periodontal fibers dislocation, and then by deepening the gingival sulcus, that is called a periodontal pocket in a moderate periodontitis. That means in moderate periodontitis you see bone loss and a pocket. So this moderate periodontitis, if it is not treated, it will lead to advanced periodontitis where you see a rapid amount of bone loss as well as a periodontal pocket. So then and there Understanding the nature and the pathogenesis of these alterations is more effective when you are diagnosing and planning a case for the treatment. So here if you see any kind of radiograph or any case, the level of bone is the consequence of past pathological diseases. That means whatever the loss which has happened due to the pathological condition, we will be seeing in the radiograph like this. Okay, so that means if you have taken the radiograph like this, that means here and all we don't have bone. So here and all it is affected by the disease. So it will be explained by the radiographs. So basically you have to understand what is the nature of and pattern of the bone loss which has happened. Thereby you can do the treatment planning, followed by. So basically these bone loss patterns are called osseous defects. Okay, so osseous defects are different types of bone deformities can result from the periodontal disease. These usually occur in adults, but also they have seen in lot of deciduous skulls. And their presence can be identified by the radiograph, but careful probing and surgical exposures which are required to determine the exact location of the bony patterns. So these osseous defects are classified into, basically they have a lot of classifications are put forward, and according to the Glickman in 1964, they has classified into osseous crater, hemiseptal defects, infrabony defects and bulbous bony contours, and inconsistent margins with ledges and reversed architecture. So if you see any teeth like this, so these are the two premolars where you can see they are surrounded by bone. Okay, they are surrounded by the bone. So this is interdental bone, this is the buccal plate, then lingual plate. And according to the Pritchard, he modified the Glickman classification, and he has modified into, he explained what is Glickman's classification first, and he also included some of the other defects like furcation involvement, anatomic elaborations of alveolar processes, exostosis, tori, dehiscence and fenestrations. So in Pritchard's classification, along with whatever the Glickman has forwarded, and the Pritchard also included other stuffs like furcation involvement and exostosis, all that. And according to Goldman and Cohen, which we latestly follow, okay, so he has classified into suprabony pocket and infrabony pocket. So what are these suprabony and infrabony pockets? Why we should know about suprabony and infrabony pockets? So when you consider it as a suprabony pocket, that means the bone loss which is happened is coronal to the pocket. Okay, so base of the crest is coronal to the pocket, whereas infrabony pocket, the base of the pocket is coronal to the crest of the mouth. So if you classify the infrabony pocket or defects are again classified into one wall defects, two wall defects, three wall defects and combined defects, and also craters. So the Goldman and Cohen also described about interradicular defects, that means between the roots. So the interradicular defects are nothing but furcation involvement. So they again classified into horizontal defects and vertical defects. So if you see the horizontal bone loss, which we commonly see, bone loss is horizontal defects, the most common pattern of the bone loss. Okay, here you can see the most common pattern of the bone loss. Bone is reduced such a way that the bony margins are approximately perpendicular to the teeth surface. If you see here, like this is the bone margin. So this is the bone margin, and this bone margin is perpendicular to the surface of the tooth. So if you draw a line, it will be horizontal line, and this horizontal line will be perpendicular to the tooth surface. So that is called horizontal bone loss, which is most commonly present in most of the defected areas. So you will see equal degree of bone loss in these patterns, and you can see here obviously this is buccal plate, behind that there is a palatal plate, and this is interdental septum where you can see normally, and here you can see a buccal plate which is lost, but there is no interdental crest or bone loss which you see here. And along with the horizontal bone loss, we also see something called vertical or angular defects. Vertical or angular defects occurs in oblique direction. Whereas you see horizontal bone loss, it is horizontal, that means the tooth is perpendicular like this. And in vertical or angular defects, where you see angular defect, it's also called arc-shaped defects. So these are the oblique defects which you can see. This creates a hollowed out trough or bone alongside the root. So all these will be seen along the sides of the roots. This also you can see angular bony defects. So So these are the certain examples of the radiographs where you see angular defects. Here you can see multiple ranges of the angular defects. Here you can see till the apical third, where you can see only this is till the middle third of the root. And here you can see the vertical defects on the mesial side of the molar. You can see there is the advanced version of the vertical defects, and this is an interradicular defect which you can see here. And here you can see the discriminate between the horizontal bone loss and the vertical bone loss. Here you can see two horizontal lines, over here two parallel lines together, and which is perpendicular to the two surface, and where these two lines are not parallel to each other. This is the oblique direction. So this is the difference between the vertical defect and a horizontal defect. Excuse me. So if you see the types of angular defects, again these angular or vertical defects are classified into, it's based again on Goldman and Cohen. They are again divided into one wall defects, two wall defects, three wall defects, and combined defects. So here if you see, what do you understand by three wall defects? That means the presence of three wall. In the defect there are three walls are present and one wall is missing. Okay. So three wall defect. So if you see the three wall defects, we know that it is an infrabony defect. That means it is happening inside the bone. So in this animated picture you can very well see that we explained about three walls which are present here and one wall is missing. That is why it is called three wall defects. If you see in the interproximal area, in this interproximal region, so the buccal plate which is not there on the root surface, okay, and then this is the distal plate and the mesial plate, and if you see here the palatal plate which is missing. So that means the presence of buccal plate, distal and the mesial, and exclusion of this palatal plate, which denotes that this is a three wall defect. And two wall defects, if you see either of the palatal or buccal wall will be missing, or either of this will distal or mesial wall will be missing. So here you can see the presence of two wall or absence of two walls is called two wall defect. Here you can see, so the buccal plate which is gone, and you can see the mesial plate is gone, buccal plate is gone, the palatal plate is present, and the distal wall is present. That means it is a two wall defect. And one wall defect, why you call this as hemiseptum? You know the other name for the one wall defect is hemiseptum. It is different from hemisection. Okay, so one wall defect, that means presence of one wall. That means only one wall among these four walls is present. So here you can see the missing palatal plate, buccal plate, mesial plate. Only the distal wall is present. That means it is one wall. I told you it is called a hemiseptum. Why do you call this as hemiseptum? Because this entire position is taken place by interdental septum. So half of this interdental septum is gone because the periodontal destruction. That's why it is called hemiseptum. That means only half of the interdental septum is present. So here you can see that, and all these osseous defects are combined in one case scenario, that is combined osseous lesions. That means if you see in this area, so coronally if it is a one wall defect, as you go down to the apex area where you see there is no buccal plate, so here there is no buccal plate, but as you go inside there is a presence of buccal plate which you clearly see in this picture. This is a perfect example of combined lesion. So the presence of the buccal plate and the mesial plate and so on, this apically, coronally you see a one wall defect, and as you go inside you see a two wall, then followed by three wall. That's it is called as combined lesion, which you see in most of the case scenarios. Okay, that was about one wall, two wall, three wall defects. And vertical defects occurring interdental can generally be seen in the radiograph. See, whatever happening in the clinical scenario, it will be explained in a 2D radiograph. So however you see this type of oblique directions in the interdental septum, it's a vertical defects as well as the furcation involvements you will see in the radiograph. The same picture if you see the clinically, here around this tooth you see here the buccal plate is gone, mesial is gone, palatal is there, and distal is there. So it is a two wall defect. And here you can see a interradicular defect as well. So if at all, if you're not able to see in the radiograph, if you open it surgically when you're doing flap surgery, you can beautifully see what is underlying, and based on the pattern of destruction, you can assess what treatment you will want to do, and followed by regenerative procedures can be attempted for such cases. And this is a cadaver where it is showing lot of interdental defects, interdental vertical defects, as well as craters, as well as interradicular defects. And osseous crater, it is one of the most common osseous defects which you generally find. Okay, so these are basically the concavities in the crest of the interdental bone. If you see this picture, this is a labial, this is labial and this is palatal, and this is a proximal side where you are seeing. That means this is the interdental area, and this is the proximal side you are seeing, buccal plate and the palatal plate. And here they are found to make 1/3 of all the defects in this, and here you see a crater or a concavity or a depression between the labial plate and the palatal plate. So it will be a saucer shaped depression you see in the interdental region, so that is called a crater. So why do you think these craters are formed so easily than your interradicular bone loss or anything else? So because of the high frequency of the interdental craters, we want to know why these craters are happening only in the interradicular region. So the interdental region collects more of plaque and calculus, because if you see anything will goes into a interdental area which you try to poke it. Okay, and we try to remove the food impacted which is there in the interdental region. So in that region, the collection of the plaque, and it is very difficult to remove. That is the reason why you get a lot of interdental craters. As well as if you see the normal flat, even slightly concave facial lingual shape also will give the interdental septum, which is especially in the lower molars. And the vascular supply from the gingiva to the center of the crest may provide pathway for the inflammation. The more inflammation, the more blood supply, the more inflammation will be there. So the more inflammation which is particularly in that region, which is giving the crater formation. So bulbous bone contours are bony enlargements caused by exostosis and adaptation to any function. So that is called buttressing bone formation. So they are found more frequently on the maxilla than on the mandible. So exostosis are basically, I have told you, there are outgrowths and they are varied in size, in number, they are nodular in size, nodular in shapes, and large nodules will be there, they are sharp and they are like projection, there are a lot of combined involvements will be there. So bone formation occurs in an attempt to buttress the bone trabeculae that weakens the bone resorption. Okay, so when it occurs in the jaw, it is called central buttressing bone formation. When it occurs in the external surface, it is called peripheral bone buttressing formation, and later the bulging of the bone contour thins, it's called lipping. Okay, then we move on to something called reverse architecture. What did you understand by reverse architecture? Reverse architecture is nothing but it is completely opposite to what is normal. What is normal? What is normal and positive architecture? That means if you see any of the architecture of the bony dentition, the interdental septa should be in a high position than the interradicular area. That means interdental area should be at the high which is more than the interradicular area. So they are produced by the interdental bone, including the facial plates, without concomitant loss of interradicular bone. That means there will be only interdental bone loss will be there. So it is completely opposite to the normal architecture of the dentition. So ledges are the plateau-like bony margins caused by the resorption of the thickened bony plates. So these are the ledges which you are seen because of the resorption of the bony ridges. And furcation involvement. The term furcation involvements refers to the invasion of this plaque and bacteria into the trifurcation and bifurcation of the root is called furcation involvement. So when there is a furcation involvement is present, it is very difficult to treat in such cases. So denuded furcation may be clinically visible sometimes, and sometimes it is not visible. Sometimes if it is not visible means it is covered by the wall of the pocket. So extent of the involvement is determined by the exploration of a blunt probe along with the simultaneous blast of warm air to facilitate visualization. And through all these mechanisms we can visualize the furcation involvement, and For this furcation involvement, the best practice is by taking a radiograph. If at all, if it is not visible, you can use a neighbor's probe in order to clinically observe the furcation involvement. And if there is furcation involvement, you can grade the furcation involvement accordingly, and then you can perform the treatment. The classification of furcation involvement is given by a lot of people, and the most prominent classification was given by the Glickman, which we practice even today. And there are a lot of drawbacks in Glickman's, where he only has taken the horizontal component, and based on the vertical component also they have been classified. And Turno and Fletcher has given based on the vertical component as well. And if you see the Glickman's classification, they have classified into grade 1, grade 2, grade 3, grade 4. Grade 1 is incipient bone loss, grade 2 is partial bone loss, you also call it as a cul-de-sac. And the grade 3 is total bone loss, but there is no through and through clinical probe which goes inside. And grade 4 furcation involvement, which is similar to the 3, and it can show a clinically visible furcation involvement by exposing the furcation area. And classification by Turno and Fletcher, I have told you it's classified into subclass A, class B, class C, and it's based on the how much amount of the bone which is involved. The class A is 0.023 to 3 mm, and the B is 4 to 6 mm, and more than 7 mm it is called class 7. And microscopically, if you see, there is no difference between the interradicular invasion of the periodontal diseases, if it goes interradicularly or interdentally. There is no change as such in the microbiological events which are taking place at the interdental area and the interradicular area. And furcation involvement is stage of progressive periodontal disease which of same etiology when compared with the interdental section or anywhere. So you should only think of the difficulties we have to overcome when we are treating this furcation involvements, because the possibility of the controlling the disease over there, the progression, the stopping of the progression of the disease in that particular area is very important. So along with that, the trauma from occlusion also, along with all these furcation involvements, along with the plaque and the local factors which are causing the periodontal diseases, along with that there is also one of the factor, that is important factor, the trauma from occlusion is also suspected to cause a loss of bone loss in the interdental region as well as in the furcation area. Other factors that may play a role in causing furcation involvement are like presence of enamel projections into the furcation area, proximity of the furcation into the cemento-enamel junction, and there are a lot of prominent other accessory canals which are present in that area which are causing the furcation involvement. So to conclude this, we know what is bone loss and how the bone loss is happening, how the progression of this bone loss is causing worsening the periodontal tissue, thereby causing different patterns of the bone loss, and then how you are going to diagnose all these, and then how you are going to treat all this is at your task. So periodontal diseases cause alterations in the morphological pattern of the alveolar bone, as we have seen lot of patterns in the loss of patterns in the alveolar bone, and they usually follow definite clinical and pathological patterns. So you have to understand, a good understanding of all these patterns is very important to treat the diseases. And also not only the patterns, you have to understand what is underlying pathogenesis, what has caused this kind of patterns in that particular disease, and these alterations will be effective in the diagnosing and treatment planning of these bone loss patterns. Thank you.